Welcome, curious minds, to another deep dive. Have you ever paused to consider how the smallest, most unassuming elements in our world can wield the most profound and far-reaching impact?
It's fascinating, isn't it? Like a tiny gear making a huge machine work.
Exactly. Think of a single seed holding the blueprint for a towering oak, or the subtle shift in a complex machine that completely alters its function. It's truly a marvel.
It really is.
Well, today we're taking that exact thought and applying it directly to something incredibly vital, your health. We're going to be talking about micronutrients,
Mhm.
those, impossibly tiny components that play truly colossal roles in literally every aspect of our well-being.
And for this deep dive, our mission is, well, it's to peel back the layers, moving beyond just the surface understanding. We want to give you a foundational, almost professional level grasp of this really intricate world of vitamins and minerals.
Like the kind of knowledge the pros have.
Precisely. We've sifted through extensive expert sources, pulling out the most vital insights, some surprising facts, and really the kind of interconnected knowledge that empowers you to, well, master this complex subject.
So the goal is making the sophisticated biochemistry of life not just accessible, but like genuinely compelling.
Exactly, making it click.
Absolutely. So what exactly are we going to unpack today? What's on the agenda?
We're broadly diving into two main categories. Vitamins first, those are the organic compounds.
Okay.
And then minerals, the essential elements. We'll break down vitamins into fat-soluble and water-soluble.
Right, the A, D, E, K versus the B's and C.
You got it. And minerals, we'll look at them by the amounts our bodies actually need. Major ones, trace ones.
And you'll discover they're incredibly diverse and critical functions, I imagine. From like how your eyes adapt to the dark, all the way to the very structure and strength of your bones.
Absolutely. And we'll touch on some surprising ways deficiencies can show up, sometimes quite subtly at first, but with potentially severe consequences.
Yeah, that's the big picture tease, right? It's remarkable to consider that while the amounts are tiny,
Microscopic, really.
any imbalance, whether it's not enough or, sometimes too much, can cascade into a whole spectrum of diseases.
It really can. And some of these conditions can have severe, sometimes irreversible consequences. This is particularly true when we talk about the growth and development of children.
Wow. It's a powerful testament to the influence these microscopic powerhouses exert over our entire physiological landscape. For the foundational framework, what are micronutrients?
Okay, let's unpack this foundational framework then. We hear vitamins and minerals all the time, but what really sets them apart, fundamentally? Let's start with vitamins. What exactly are they?
Okay, so vitamins are essentially organic compounds. That means they contain carbon, and they tend to have more complex molecular structures.
Organic meaning carbon-based.
Yep,
Got it.
right. And our bodies need them, but in really small, sometimes minuscule amounts. They're vital for maintaining health and ensuring normal growth.
But the key is
Yeah.
we can't make them ourselves. That's the absolute key distinction. Our bodies either can't synthesize them at all or not in sufficient quantities. So they must come from our diet. That external requirement is precisely what makes them essential nutrients.
That must obtain from diet part. Yeah, that feels critical. Now, you mentioned these organic essentials are further categorized. Walk us through the two main types and their sort of broad functional differences.
Certainly. We group vitamins into two major categories based on how they dissolve, which really dictates how our bodies handle them. First up, the fat-soluble vitamins.
That's A, D, E, and K.
Exactly. A, D, E, and K. Being fat-soluble means they literally need dietary fat to be absorbed properly in the gut.
Makes sense.
And once absorbed, they can be stored mainly in our body's fatty tissues and significantly in the liver. This storage capability means deficiencies usually take longer to develop compared to the other group.
Ah, so you can build up reserves.
You can. And their functions, incredibly diverse. They control protein synthesis. Some act almost like hormones. Think vitamin D regulating calcium. Others are powerful antioxidants, like vitamin E protecting our cells. And vitamin A is crucial for regulating tissue growth and differentiation.
So they can accumulate, meaning you don't necessarily need a daily dose if your stores are good. What about the water-soluble ones? That sounds like a totally different storage situation.
Precisely. A completely different story. The second group is the water-soluble vitamins. This includes the entire B-complex family, B1, B2, B3, B6, B12, folate, biotin, pantothenic acid, and vitamin C.
Ones you usually find in those multivitamin fizzy drinks.
Often, yes. Their primary role is generally different too. They typically function as precursors for coenzymes.
Coenzymes.
Yeah, and think of them as tiny helpers, like essential tools or lubricants that keep our cellular machinery running smoothly. They act as catalysts and crucial substrates in a huge array of metabolic reactions inside our cells.
Okay, so less about structure, more about making reactions happen.
Generally speaking, yes. And unlike the fat-soluble ones, they're usually not stored in the body. Vitamin B12 is the big exception here. It can be stored. But for the most part, what you don't use, you excrete, primarily in urine. This non-storage means if your diet is lacking, deficiencies can pop up much faster, sometimes in weeks or months, not years.
And it also means toxicity is less likely because your body just gets rid of the excess.
Exactly. It's much harder, though not impossible in extreme cases, to reach toxic levels with most water-soluble vitamins compared to fat-soluble ones.
That fundamental difference in storage and excretion, that's a really critical insight. It directly impacts how fast a deficiency might show up. Okay, let's shift gears. From organic compounds to essential elements, let's talk minerals. What defines them? How are they different from vitamins?
Minerals are inorganic essential elements. They don't contain carbon like organic compounds do, but they are absolutely critical for supporting countless biochemical processes. They're involved in both cell structure and function.
So, less complex chemically, but just as vital.
Absolutely vital. Think of them as the true building blocks, the structural framework, and the precise regulators for everything from forming bones to conducting nerve impulses.
And what are some of the key players we should be aware of? The sources listed quite a few.
Yeah, there's a good list. The really important ones we'll likely touch on today include calcium, magnesium, phosphorus, potassium, sodium, chloride. Those are often major minerals.
Right, electrolytes and bone stuff.
Exactly. And then the crucial trace minerals like iron, zinc, copper, iodine, and selenium. Each of these, even in tiny amounts, has specialized vital roles. And then there are others like cobalt, manganese, molybdenum, nickel, sulfur, each playing its own subtle but essential part.
Wow, even the trace elements, the ones needed in tiny amounts, are absolutely non-negotiable for health. Can you categorize them based on how much we need daily?
Yes, that's the standard way. We talk about major minerals, which we need in amounts greater than 100 milligrams per day. That's your sodium, potassium, chloride, calcium, magnesium, phosphorus.
The big players?
Right. Then we have the trace minerals needed in much smaller amounts, less than 100 milligrams per day. Think iron, copper, zinc, iodine, selenium.
Still essential, just less quantity.
Correct. And finally, there are ultra-trace minerals, required in truly minuscule amounts, often less than 1 milligram per day. Their specific roles are sometimes still being fully mapped out, but we know they're necessary.
So what's the big picture consequence when these mineral balances are off, if you don't have the right amounts?
Well, here's where it gets really interesting and frankly a bit sobering. Even marginal, not just severe imbalances in these trace elements, are recognized risk factors for several serious diseases.
Really? Even marginal?
Yes. We often focus on iron deficiency anemia or iodine deficiency goitre, which are major issues. But our sources highlight that problems with copper, zinc, and selenium can also lead to significant distinct health problems. It powerfully underscores that balance is absolutely everything in this incredibly complex, interconnected biological system.
That brings us to a really critical insight, especially for the youngest among us. There's a specific note in our source material about breast milk and micronutrients. It's often called the perfect infant food.
And for a very good reason, it is the ideal food for infants.
But it does have a couple of key deficiencies we need to know about.
It absolutely does. This is crucial information for parents and caregivers. While breast milk is unparalleled, it is specifically deficient in two key vitamins, vitamin D and vitamin K.
Okay, D and K. Let's start with vitamin D in breast milk. What's the specific concern there, given its role in bone health?
Breast milk contains only about 30 to 40 international units, IU, of vitamin D per liter. It's significantly lower than the recommended daily allowance, RDA, for infants.
How much lower?
The RDA is typically 400 IU per day. So exclusively breastfed babies require that 400 IU per day supplementation. Without it, they're at high risk of developing rickets, a condition where bones soften and deform because they aren't mineralizing properly.
And even formula-fed babies might need it.
Potentially, yes, if they're consuming less than about a liter of formula per day. Formula is usually fortified to provide 400 IU per liter, but if intake is lower, supplementation might still be needed.
Okay, that's vitamin D. What about vitamin K? That's another vital one for newborns, especially since their gut bacteria aren't established yet, right?
Precisely. Vitamin K is normally produced by our gut microflora, the bacteria living in our intestines. But a newborn's gut is essentially sterile at birth and takes time to get colonized.
So no internal production initially.
Right. Combine that with the fact that breast milk is also a poor source only about 2 micrograms per liter of phylloquinone, which is the K1 form, and you have a vulnerability.
And the consequence?
This deficiency is so critical that all babies should receive vitamin K right at birth. This is to prevent hemorrhagic disease of the newborn, or HDN.
Which sounds serious.
It is.
Yeah.
It's a potentially life-threatening bleeding disorder. That prophylactic shot or oral dose of vitamin K given routinely at birth is a standard, truly life-saving intervention globally. Fat-soluble vitamins, deeper dives into their mechanisms and consequences.
Okay, that's a really solid foundational overview. Now let's dive much deeper into the fat-soluble vitamins. Let's kick things off with vitamin A, also known as retinol. We usually link it with vision, but its roles are much broader, aren't they?
Indeed. Vitamin A, or retinol, is remarkably versatile. We can get it in 2 main ways. First, from plant pigments called carotenoids, often referred to as provitamin A.
Like beta-carotene in carrots.
Exactly. Think carrots, dark leafy greens, squash. Our bodies convert these carotenoids into retinol. The other way is getting preformed vitamin A directly from animal sources. Liver is a big one. Fish liver oils, egg yolk, milk.
And once we get it, where does it go?
It gets absorbed and then primarily stored as retinol palmitate in the liver. From there, the liver converts it into its active forms as needed. Retinol and retinoic acid, these are the forms that actually do the work in our cells.
And because it's fat-soluble, absorption needs fat, right? You mentioned that general principle.
Absolutely. It needs dietary fat. It gets packaged up and absorbed as part of chylomicrons. Think of them as tiny lipid taxis.
Lipid taxis, I like that.
They transport dietary fats and fat-soluble vitamins along with them, from the intestines out to the rest of the body. This is why conditions that mess with fat absorption, like celiac disease, cystic fibrosis, certain liver problems, can significantly increase the risk of vitamin A deficiency.
Makes perfect sense. Okay, let's get into the nitty-gritty of its physiological functions, especially that intricate role in vision. The whole process of turning light into sight just blows my mind.
It truly is elegant biochemistry. Retinol plays an absolutely critical role, especially in night vision, how well you see in dim light.
Okay.
The process starts in your eyes' photoreceptor cells, the rods and cones. Inside these cells, a specific form of retinol, called 11-cis-retinol, is bound to a protein, typically rhodopsin in the rods.
So retinol plus protein equals light sensor.
It's essentially yes. Now, when light enters your eye and strikes this rhodopsin-retinol complex, something amazing happens. The 11-cis-retinol instantly changes its shape. It isomerizes into the all-trans form.
Light flicks a switch.
It literally does. This shape change causes the retinol to detach from the rhodopsin protein. This whole event is often called bleaching. And that separation, that bleaching, is the trigger. It initiates a cascade of events that generates a nervous impulse.
Which then travels to the brain.
Exactly. Travels along the optic nerve straight to your brain's visual cortex, and boom, you perceive light. You see?
So it's literally the molecule that bridges light energy and neural signals. What happens to that all-trans retinol after it detaches? Is it just used up?
No, the body is smarter than that. That's the ingenious part. It gets recycled. Through a series of enzymatic reactions, that all-trans retinol is converted back into the 11-cis-retinol form.
Ready to go again.
Ready to bind with opsin again and detect the next photon of light. Now, here's the crucial link to deficiency. If you don't have enough vitamin A, this regeneration cycle slows down. The reformation of rhodopsin is inhibited.
Meaning you can't reset the system quickly?
Precisely. Which directly impairs your ability to adapt to low light. That's why one of the earliest, most classic signs of vitamin A deficiency is night blindness, or nyctalopia. You just can't see well in the dark because those visual pigments aren't regenerating efficiently.
Fascinating. Okay, beyond just seeing, you said vitamin A is also crucial for growth and cell differentiation. How does it manage that? Seems like a totally different job.
It does, but it's linked through gene expression. Both retinol and its derivative, retinoic acid, act like signaling molecules. They bind to specific receptors inside our cells.
Nuclear receptor?
Often, yes. These receptor vitamin complexes then move into the cell nucleus and basically act like master switches. They bind to specific regions on our DNA and regulate the transcription of certain genes, turning them on or off.
So they're controlling which proteins get made?
Exactly. And that dictates the synthesis of proteins vital for proper growth, development, and how cells specialize into different tissues. So vitamin A is fundamentally involved in directing how our cells mature and function system-wide.
And it also helps maintain healthy tissues, right? Like our skin and the linings of our lungs and gut, almost like a protective barrier.
Absolutely. Retinol is required for the synthesis of glycoproteins and mucus. These are essential components for maintaining the integrity and function of epithelial tissues.
Epithelial tissues, those are the linings.
Yes, the linings of our respiratory tract, our gastrointestinal tract, our urinary tract, and also our skin. They form a critical barrier. Vitamin A deficiency leads to drying and thickening hyperkeratinization of these surfaces.
Making them less effective barriers.
Exactly. It compromises their protective function, making the body more vulnerable to infections entering through those surfaces.
Okay, so given all these absolutely critical roles, vision, growth, immunity, tissue integrity, where do we get this multi-talented vitamin? What are the go-to sources?
Good question. Our sources highlight two main categories. For carotenoids, the provitamin A, look for vibrant colors in plants. Green and yellow veggies and fruits.
Carrots, obviously.
Carrots are the classic example, yes. But also dark green leafy vegetables like spinach and kale, squash, sweet potatoes, mangoes, oranges, tomatoes. Beta-carotene is the major player here.
And the other type, preformed vitamin A.
Right, preformed vitamin A retinol comes from animal sources. The richest are liver, beef liver, chicken liver, fish liver oils like cod liver oil, also egg yolks, whole milk, butter, cheese.
And fortification, is it added to foods?
Yes, that's important too. Many processed foods like breakfast cereals, milk, margarine, and especially infant formulas are fortified with preformed vitamin A to help ensure adequate intake, particularly for vulnerable groups like young children.
Good to know. And what are the typical daily requirements? How much do we actually need?
The recommended daily allowance, or RDA, varies by age. For infants, it's generally around 300 to 400 micrograms of retinol activity equivalents, or RAE. Yeah, it's a way to account for the different bioactivity of retinol and carotenoids. But roughly, think 300, 400 rings for infants. For young children, it increases to maybe 400 to 600 grams. And for adolescents and adults, it's around 700 grams for women and 900 grams for men.
And there's that IU conversion, too.
Right. Sometimes you see in international units, IU. The conversion isn't straightforward because it depends on the form. But roughly 1 gram of retinol is about 3.3 IU. It helps when looking at supplement labels sometimes.
Okay. Now, despite knowing all this, vitamin A deficiency, VAD, is still a massive global health issue, particularly in certain parts of the world. Can you describe how it manifests, from the mild signs to the really devastating outcomes?
Tragically, yes, VAD remains a preventable scourge. Mild deficiency might show up as follicular hyperkeratosis.
What's that look like?
It's basically rough, bumpy skin, sometimes described as goose flesh that doesn't go away, often on the arms and thighs. It's due to keratin buildup in the hair follicles. But the more characteristic early clinical feature, as we discussed, is night blindness. Trouble seeing in dim light. That's often the first clue.
So those are the earlier warnings. But it can get much worse, especially for the eyes, right?
Yeah.
You mentioned xerophthalmia.
Yes, xerophthalmia is the umbrella term for the eye manifestations of VAD. And it progresses in stages if untreated. It starts with dryness of the conjunctiva, the clear membrane over the white of the eye.
Just dryness.
Dryness. And then you might see Batot spots. These are small, foamy, almost cheesy-looking patches that appear on the conjunctiva. They're basically accumulations of keratin debris, mucus, and bacteria.
Okay, that sounds unpleasant, but maybe not sight-threatening yet.
Not yet, but it's a clear sign of significant deficiency. If it progresses further, the cornea, the clear front part of the eye, also becomes dry, and then opaque, cloudy. This is corneal xerosis and ulceration.
Ulceration, that sounds bad.
It is very bad. The cornea can literally soften and dissolve, a condition called keratomalacia. This often leads to infection, rupture of the eye, and permanent irreversible blindness. It's a true medical emergency.
Devastating. And beyond the eyes, what are the broader systemic impacts? You mentioned weakened barriers.
Yes, that compromised integrity of the mucosal linings in the respiratory and gastrointestinal tracts is huge. It strips away that first line of defense.
Making kids more susceptible to infections.
Dramatically more susceptible. VAD significantly increases the risk and severity of common childhood infections like diarrhea, pneumonia, and especially measles. Measles in a VAD-deficient child is far more likely to be severe, complicated, and fatal.
So it's not just about blindness.
Not at all. VAD is a major contributor to overall child mortality in many developing countries. It impairs the immune system directly, too. Children who are generally malnourished or have conditions causing fat malabsorption are, of course, at the highest risk.
How is VAD diagnosed then? And crucially, how is it treated, especially if it's reached those dangerous stages?
Diagnosis usually involves looking for those clinical signs, taking a dietary history, and often confirming with blood tests measuring serum retinol levels. A level below, say, 15 or 20 micrograms per deciliter is generally considered deficient.
And treatment.
Treatment involves giving high-dose oral vitamin A supplementation. The WHO protocol uses specific doses based on age. For infants under 6 months, it's 50,000 IU. For 6 to 12 months, 100,000 IU. And for children over 1 year, it's a large dose of 200,000 IU.
Just once.
Usually the dose is repeated the next day and then again after a few weeks, typically 4 weeks later, to build up stores. Parenteral or injected vitamin A is used if the child has persistent vomiting or severe malabsorption.
And if the cornea is already involved, that emergency situation.
If there's any sign of corneal clouding or ulceration, keratomalacia, that requires immediate urgent treatment, usually with injected vitamin A, alongside appropriate eye care, often antibiotics, to try and save vision. It's critical.
This sounds like something that really needs large-scale public health action, not just individual treatment. Are there programs for this?
Absolutely. Prevention is key. Many countries with high VAD prevalence have national supplementation programs. India, for example, has the National Vitamin A Prophylaxis Program.
What does that involve?
It historically targeted children aged 1 to 5 years, but now often focuses on under 3s who are most vulnerable. To improve coverage, they've cleverly linked the first 2 high doses with routine immunization schedules.
Ah, smart. Piggybacking on existing health visits.
Exactly. So 100,000 IU is given with the measles vaccine around 9 months, and then 200,000 IU with the DPT booster around 15-18 months. In highly endemic areas, additional doses might be given every 6 months.
Does supplementation fix the whole problem?
It's a vital intervention, especially for preventing blindness and reducing mortality. But it's not a magic bullet. Long-term sustainable prevention really requires improving dietary diversity, promoting consumption of vitamin A-rich foods, along with addressing underlying malnutrition and infections. Food fortification is also a key strategy.
Right. Supplementation is crucial, but improving the baseline diet is the ultimate goal. Okay, a quick, interesting side note. Carotenemia. This happens when people eat way too many carrots, right? Makes your skin yellow.
Yes, exactly. It's a benign condition, completely harmless. When someone consumes excessive amounts of carotene-rich foods, carrots are the classic, but also squash, sweet potatoes, the carotenoids can get deposited in the skin.
Where does the yellow show up most?
It's most noticeable on the palms of the hands, the soles of the feet, and around the nose and mouth. But the key distinguishing feature, which differentiates it from jaundice, is that the sclerae, the whites of the eyes, remain white.
Oh, okay. Jaundice affects the eyes too.
Correct. Carotenemia doesn't, and it's fully reversible. Once the person reduces their intake of high carotene foods, the yellow tinge fades away over a few weeks. Nothing to worry about.
Good to know. But on the flip side, we do need to worry about hypervitaminosis A and its potential for teratogenicity. Too much of this good thing can definitely be a problem.
This is a very important caution. Vitamin A is fat-soluble, meaning it can accumulate in the body to toxic levels if intake is excessively high over a prolonged period.
How high is too high?
Toxicity, or hypervitaminosis A, typically occurs with chronic ingestion of very large doses, often exceeding 50,000 IUs per day for several months. This usually comes from overzealous use of supplements like fish liver oil or high-dose therapeutic preparations, sometimes used for acne, for instance.
What are the signs of acute toxicity?
Acutely, very high doses can cause pseudotumor cerebri. This mimics a brain tumor, with increased pressure inside the skull causing symptoms like severe headache, nausea, vomiting, irritability, blurred vision, and in infants, a bulging fontanelle.
Scary. And chronic toxicity.
Chronic overconsumption leads to a different set of symptoms.
Right.
Anorexia, dry, itchy skin, hair loss, alopecia, cracked lips, bone and joint pain, and enlarged liver and spleen, hepatosplenomegaly.
But the most serious concern is during pregnancy. Teratogenicity.
Yes, that's the most critical danger. High doses of preformed vitamin A retinol, especially taken during the early stages of gestation, are known teratogens, meaning they can cause serious birth defects affecting the baby's heart, nervous system, and craniofacial development.
So pregnant women need to be really careful with supplements.
Extremely careful. The World Health Organization advises that vitamin A intake during pregnancy should generally not exceed 10,000 IU or 3,000 GHAI daily or 25,000 IU, 7,500 GHAI weekly. This is why vitamin A supplementation during pregnancy is handled very cautiously and usually only recommended in areas with severe deficiency under medical supervision. It's also why high-dose retinol medications like isotretinoin for acne are strictly contraindicated during pregnancy.
Okay, a crucial warning there. Let's move on from vitamin A. Next up in the fat-soluble lineup is the sunshine vitamin, vitamin D. We know it's vital for bone health, but how does it actually get into our bodies and become active? It's unique, right?
It is unique because, unlike other vitamins, our bodies can synthesize a significant amount of it endogenously. It's produced right in our skin.
From sunshine.
From exposure to solar ultraviolet B, UVB radiation, specifically light within the 293 and 15 nanometer wavelength range. This UVB light converts a precursor molecule in the skin, called 7-dehydrocholesterol, into pre-vitamin D3, which then quickly converts to vitamin D3, copalciferol.
So under normal conditions, with enough sun, we might make enough.
Often, yes. Sufficient sun exposure can potentially meet the body's needs. However, sufficient depends on many factors. And when endogenous production isn't enough, diet becomes crucial.
So we can make D3 in our skin. What are the dietary forms?
There are two main dietary forms. Vitamin D2, ergocalciferol, comes from plant sources like fortified mushrooms or supplements. And vitamin D3, cocacalciferol, comes from animal sources, fatty fish like salmon and mackerel, fish liver oils, egg yolks, and fortified foods like milk and cereals. D3 is the same form we make in our skin.
Is one better than the other, D2 versus D3?
There's some debate, but many studies suggest D3 might be slightly more effective at raising and maintaining blood levels of vitamin D compared to D2. Both, however, need to be activated in the body.
Right, the activation process. How does that work? Where does it happen?
Okay, so whether it comes from your skin or your diet, as D2 or D3, the first stop is the liver. In the liver, an enzyme adds a hydroxyl group, OH, to the molecule, converting it into 25-hydroxyvitamin D, or 25-OHD, sometimes called calcidiol.
And this 25-OHD is what doctors measure in blood tests.
Exactly. This 25-OHD is the major circulating form of vitamin D and has a relatively long half-life, about 2 to 3 weeks. So measuring its level in the blood gives the best assessment of your overall vitamin D status. It reflects both skin production and dietary intake.
So the liver does step one, but that's not the fully active form yet.
Correct. The crucial second activation step happens primarily in the kidneys. Another enzyme called 1-alpha-hydroxylase adds a second hydroxyl group. This converts 25-OHD into 1025-dihydroxyvitamin D, or 1025-OH2D. This molecule, also known as calcitriol, is the fully active hormonal form of vitamin D.
The one that actually does the job in the body.
Precisely. It's the biologically potent form that carries out vitamin D's main functions, particularly regulating calcium and phosphate.
And how is that critical kidney enzyme, 1-alpha-hydroxylase, regulated? I imagine the body wants tight control over this powerful hormone.
Absolutely. It's a finely tuned system. The activity of 1-alpha-hydroxylase is tightly regulated by several factors, mainly driven by the body's need for calcium and phosphate.
How so?
When blood calcium levels drop, the parathyroid glands release parathyroid hormone, PTH. PTH travels to the kidneys and stimulates 1-alpha-hydroxylase activity, leading to more production of active calcitriol.
So low calcium, more PTH, more active vitamin D.
Exactly. Low blood phosphate levels also directly stimulate the enzyme. Conversely, high levels of calcium and phosphate tend to suppress it. And another key player is fibroblast growth factor 23, FGF23, a hormone released from bone cells, which strongly inhibits 1-alpha-hydroxylase. Active vitamin D itself also provides negative feedback, reducing its own production. It's a complex feedback loop.
Wow, okay. So now we have the active form, calcitriol, 1025-OH2D. How does it perform its famous calcium dance and influence bone health? What does it actually do?
Calcitriol acts on several key target tissues to increase blood calcium and phosphate levels. Its primary targets are the intestines, the bones, and the kidneys.
Let's start with the intestines.
In the intestine, calcitriol dramatically increases the absorption of dietary calcium and phosphate. It does this by stimulating the intestinal cells to produce specific calcium-binding proteins and transport channels that pull these minerals from your food into your bloodstream.
So it makes your gut better at grabbing calcium and phosphate.
Exactly. Then, in the kidneys, calcitriol works alongside PTH to increase the reabsorption of calcium back into the blood, preventing it from being lost in the urine. It has a similar but more complex effect on phosphate reabsorption, too.
Okay, saving minerals from being excreted. What about its effect on bone? Does it build bone or break it down?
This is where it's a bit nuanced. Calcitriol is absolutely essential for normal bone mineralization, the process of hardening bone by depositing calcium and phosphate. Without enough active vitamin D, bone matrix doesn't mineralize properly, leading to soft bones, rickets osteomalacia. However, calcitriol also works with PTH to stimulate the activity of osteoclasts, the cells that break down bone tissue.
Why would it break down bone?
to release stored calcium and phosphate from the bone into the bloodstream if blood levels are too low. It's about maintaining critical blood mineral levels, even sometimes at the expense of the skeleton in the short term. So the overall net effect of active vitamin D is to increase serum levels of both calcium and phosphate, ensuring there's enough available for nerve function, muscle contraction, and ultimately proper bone mineralization when conditions are right.
A very complex rule. Okay, given all this, let's revisit the sources. What are the main dietary sources, and what factors can really hinder our ability to make it from the sun?
Dietary sources naturally aren't super abundant. The best are fatty fish like salmon, mackerel, herring, and sardines, plus fish liver oils. Egg yolks contain some, as do UV-exposed mushrooms for D2. Many countries fortify foods like milk, yogurt, orange juice, and breakfast cereals, which can be significant sources.
But generally, food alone isn't enough for most people.
Often not, unless you eat a lot of fatty fish or heavily rely on fortified foods. That's why sun exposure is so important. But many factors affect how much vitamin D you synthesize in your skin.
Such as?
Time of day, UVB strongest midday. Season, less UVB in winter. Latitude, less UVB further from the equator. Altitude, cloud cover, air pollution. These all reduce UVD penetration.
What about personal factors?
Skin pigmentation is a major one. Melanin acts as a natural sunblock, so individuals with darker skin tones require significantly longer sun exposure to produce the same amount of vitamin D as someone with lighter skin. Age is another factor. Older skin is less efficient at producing vitamin D. And of course, sunscreen use, which is important for skin cancer prevention, blocks UVB rays, as does extensive clothing coverage. Lifestyle factors, like spending most time indoors, also limit synthesis.
So, lots of variables affecting sunshine synthesis. What are the recommended daily requirements, and who specifically needs supplementation?
Supplementation is generally recommended when adequate sun exposure isn't feasible or reliable. This applies particularly to exclusively breastfed infants, as we discussed. Breast milk is low in vitamin D, so they all need 400 IU day supplementation starting shortly after birth.
What about formula-fed infants?
Infant formula is fortified with vitamin D, usually at 400 IU per liter. So if an infant drinks at least a liter, about 32 ounces of formula per day, they're likely getting enough. But partially breastfed infants, or those drinking less formula, might still need supplements.
Who else is at high risk and should consider supplementation?
People with limited sun exposure due to lifestyle, clothing, geography. Those with darker skin, older adults, people with obesity, vitamin D gets sequestered in fat tissue, individuals with malabsorption syndromes, like Crohn's, celiac, and those taking certain medications that interfere with vitamin D metabolism. Pregnant and lactating women also have needs around 600 IU day.
Okay, that covers requirements. Now let's talk about the classic disease of vitamin D deficiency, rickets. What exactly is it, and why the name twisted bones?
Rickets is fundamentally a disease of growing bone in infants and children. It's characterized by defective mineralization of the bone matrix and, critically, of the cartilaginous growth plates at the ends of long bones.
So the bones don't harden properly while they're growing.
Exactly. This leads to soft, weak bones that are prone to bending and deformation under the stress of weight bearing. The name rickets likely comes from an Old English word ricken, meaning to twist, aptly describing the characteristic bony deformities like bowed legs or knock knees.
What's the most common cause?
By far, the most common cause globally is nutritional vitamin D deficiency. Less commonly, severe dietary deficiency of calcium or phosphate can also cause rickets, but vitamin D deficiency is the main culprit.
So how does that vitamin D deficiency actually lead to those twisted bones? Can you walk us through the pathophysiology, that chain reaction you mentioned earlier?
Sure. It starts with low vitamin D. This leads to decreased intestinal absorption of calcium and phosphate. The body senses the falling blood calcium, hypocalcemia, and responds by increasing the secretion of parathyroid hormone, PTH, from the parathyroid glands.
PTH tries to fix the low calcium.
Right. PTH acts on the bone to stimulate the release of calcium and phosphate into the blood, bone resorption. It also acts on the kidneys to increase calcium reabsorption. So PTH is often successful in restoring blood calcium levels back towards normal, at least initially.
Okay, so blood calcium might look normal, but what's the catch?
The catch is PTH's effect on the kidneys regarding phosphate. While PTH saves calcium, it simultaneously increases the excretion of phosphate in the urine. This leads to low serum phosphate levels, hypophosphatemia.
Ah, so calcium might be okay, but phosphate drops. Why is low phosphate the problem for bones?
Phosphate is absolutely essential for the mineralization process at the growth plates. These are the areas of cartilage at the ends of long bones where bone growth actually happens. Normally, cartilage cells mature die off, apoptosis, and are replaced by mineralized bone. Low phosphate disrupts this process.
Wow.
The cartilage cells continue to proliferate and hypertrophy, get bigger, but they fail to undergo apoptosis and don't get properly mineralized. This leads to widening, disorganization, and thickening of the growth plate, causing the characteristic swellings at the wrists, knees, and ankles seen in rickets.
And the bending with the long bones.
That comes from the defective mineralization of the bone shaft itself, the osteoid, or bone matrix. This condition is called osteomalacia. The bone is laid down, but it doesn't harden properly. So when a child starts walking, the soft, unmineralized, weight-bearing bones, like the femur and tibia, simply bend under the stress, leading to bow legs or knock knees.
Osteomalacia. You mentioned it briefly before. How is that different from osteoporosis again, just to clarify?
Good distinction. Osteomalacia is a problem of bone quality. There's enough bone matrix, osteoid, but it's poorly mineralized, making it soft. I think soft bones. It occurs in both children, as rickets, and adults.
Yeah.
Osteoporosis, on the other hand, is a problem of bone quantity. The bone is normally mineralized, but there's simply less of it overall. The bone architecture is weakened, making it brittle and prone to fracture. Think porous bones.
Got it. Quality versus quantity. So nutritional rickets is the main type. What are the key clinical features a parent or doctor might see?
The signs can vary depending on the child's age and the severity of the deficiency. In infants, you might see delayed closure of the fontanelle soft spots, frontal bossing, a prominent forehead, and craniotaves, where the skull bones feel soft and can be indented like a ping pong ball. As the child gets older, you see the characteristic enlargement of the wrists and ankles due to the widened growth plates. The rachitic rosary is another classic sign, bead-like bumps along the costochondral junctions where the ribs meet the cartilage near the sternum. A horizontal groove along the lower chest, called Harrison's sulcus, can also appear due to the pull of the diaphragm on the soft ribs.
On the leg deformities.
Yes, the limb deformities become apparent once the child starts walking bow legs, genu-varum, or knock knees, genu-valgum. There can also be delayed dentition, enamel defects, muscle weakness, hypotonia, bone pain leading to irritability or reluctance to walk, and an increased risk of fractures. In severe cases, low calcium can cause seizures, hypocalcemic tetany.
Quite a range of signs. How do doctors typically diagnose rickets? What tools do they use?
Diagnosis relies on a combination of factors, like careful history, looking for risk factors like low vitamin D intake, limited sun exposure, exclusive breastfeeding without supplementation, the characteristic clinical findings on physical examination, and confirmation with laboratory tests and x-rays.
What do the lab tests show?
Blood tests typically reveal low or normal serum calcium, low serum phosphate, and significantly elevated serum alkaline phosphatase, ALP. ALP is an enzyme released by active bone-forming cells, osteoblasts, and its level skyrockets in rickets as the bones try desperately to mineralize. Measuring serum 25-OHD is crucial to confirm vitamin D deficiency levels below 10-12 ngml are generally considered deficient, while 12-20 ngml is insufficient. PTH levels are usually elevated too.
And x-rays. What do they reveal?
X-rays, especially of the wrists and knees, are very helpful and show characteristic changes at the metaphysis, the growing end of the bone. You'll see widening of the growth plate space, and the end of the bone appears frayed, cupped, and splayed instead of having a sharp, clear edge. The overall bone density might look reduced, osteopenia, and bowing deformities of the long bones can be clearly seen.
So the x-rays really show that lack of mineralization at the growth zone. Once diagnosed, what's the management strategy? How do you treat nutritional rickets?
The primary treatment is, logically, to replenish vitamin D stores and provide adequate calcium and phosphate for bone healing. This involves giving vitamin D supplements.
What kind of doses?
There are different regimens. Historically, very large single doses, dose therapy, were used, but current recommendations often favor daily administration over several weeks or months. For example, daily doses might range from 2,000 IU for infants up to 6,000 IU for older children and adolescents, typically continued for about 12 weeks, followed by a lower maintenance dose.
Is vitamin D enough? What about calcium?
Good point. Providing adequate calcium is also crucial during the healing phase, as the bones will be rapidly taking up minerals. Oral calcium supplements, around 30-75 milliagar a day of elemental calcium, are usually given concurrently with the vitamin D therapy, often for the first couple of months.
How do you know if the treatment is working?
Healing is monitored both clinically and biochemically. Serum phosphate levels usually start to rise within a few days, followed by a gradual decrease in the elevated ALP over weeks to months. Radiological evidence of healing on X-rays, seeing that metaphyseal line becomes sharper and denser, typically appears within 2 to 4 weeks. Clinical improvement, like reduced bone pain and improved muscle strength, also occurs.
What if it doesn't work? What if the x-rays don't show healing despite adequate treatment?
Ah, that's when you suspect refractory rickets. This means the rickets isn't responding to standard nutritional therapy, suggesting a different underlying cause.
Right, refractory rickets. Let's delve into that. What are the main possibilities when rickets doesn't respond?
Refractory rickets encompasses a group of disorders where the problem isn't simply a lack of dietary vitamin D or calcium. Broadly, they fall into two main categories. One, defects in vitamin D metabolism or action. These are often rare genetic disorders where the body either can't properly activate vitamin D or the target cells can't respond to the active form. Two, phosphate wasting disorders. These conditions involve excessive loss of phosphate in the urine, leading to hypophosphatemia that prevents bone mineralization, even if vitamin D levels are normal.
Okay, let's touch on the vitamin D metabolism defects first. You mentioned vitamin D-dependent rickets, VDDR.
Yes, these are usually autosomal recessive genetic conditions. VDDR type I is caused by a deficiency in the kidney enzyme 1-alpha hydroxylase that performs the final activation step. So these individuals have plenty of 25-OHD, but markedly decreased levels of the active 1025-OH2D. They present with severe rickets early in infancy, often with hypocalcemia. Treatment requires giving physiological doses of already active vitamin D, calcitriol, or its precursor, alpha-calcidiol.
And VDDR type 2.
VDDR type 2 is different. Here, the problem is end organ resistance. The kidneys make plenty of active 1025-OH2D. In fact, levels are usually markedly raised, but the target cells, intestine, bone, kidney, lack functional vitamin D receptors, so they just don't respond to the hormone signal.
Like the signal is being sent, but nobody's listening.
Exactly. Clinically, it resembles type I, but is often more severe and harder to treat. A characteristic feature frequently seen in type 2, but not type 1, is alopecia, hair loss, and other ectodermal defects like dental abnormalities or skin cysts. Treatment is challenging, sometimes requiring massive doses of calcium, often given intravenously.
Fascinating genetic conditions. What about the other main category, the phosphate problems?
The most common cause of refractory rickets overall is familial hypophosphatemic rickets, FHR, particularly the X-linked dominant form, XLH.
So this is primarily about losing too much phosphate.
Precisely. These are inherited disorders leading to excessive phosphate wasting by the kidneys. The underlying defect on XLH involves the feast gene, which leads to overproduction of that hormone, FGF23.
FGF23 again. What does high FGF23 do?
High FGF23 tells the kidneys to dump phosphate into the urine, causing hypophosphatemia. It also suppresses the 1-alpha hydroxylase enzyme in the kidney, leading to inappropriately low levels of active 1025-OH2D, even though the low phosphate should be stimulating it.
A double whammy for bone mineralization.
Exactly. Clinically, these children have rickets, often with prominent lower limb deformities, bowing, knock knees, and short stature. They may also have dental problems like frequent abscesses. A key difference from VDDR is that they typically do not have hypercalcemia or symptoms like tetany.
How is FHR treated?
Treatment aims to replace the lost phosphate and bypass the low-active vitamin D. It involves lifelong administration of oral phosphate supplements taken multiple times a day, which can cause diarrhea, combined with active vitamin D analogs like calcitriol or alpha-calcidiol. Careful monitoring is essential.
Are there other causes of rickets beyond these main categories?
Yes, several other conditions can cause or mimic rickets. Chronic kidney disease, CKD, is a major one. Damaged kidneys can't activate vitamin D properly, low 1-alpha hydroxylase activity, and also have trouble handling phosphate. Renal tubular acidosis, RTA, a condition where the kidneys can't handle acid properly, can also lead to phosphate wasting and rickets. Certain tumors can rarely produce FGF23, causing oncogenous rickets, and some skeletal dysplasias, genetic bone disorders, can look like rickets on X-ray, but lack the characteristic biochemical abnormalities. Finally, chronic fluoride intoxication, fluorosis, in endemic areas can cause bone pain and deformities mimicking rickets.
Wow, quite a differential diagnosis for rickets. Okay, that's an incredibly thorough look at vitamin D and its deficiency states. Let's shift to the next fat-soluble vitamin. Vitamin E, tocopherols, its main job is antioxidant, right? Protecting cell membranes.
That's its primary and most well-known function, yes. Vitamin E refers to a group of related compounds, the tocopherols and tocotrienols, with alpha-tocopherol being the most biologically active form. They're lipid-soluble antioxidants.
Meaning they work in fatty environments.
Exactly. Their key role is to protect polyunsaturated fatty acids, PUFAs, within cell membranes from damage caused by oxygen-free radicals. PUFAs are very susceptible to oxidative attack, and vitamin E acts like a bodyguard, neutralizing these damaging radicals and preventing a chain reaction of lipid peroxidation that could destroy the membrane.
So it keeps our cell walls intact and functional. How is it absorbed?
Like other fat-soluble vitamins, its absorption from the gut requires dietary fat, bile acids, and pancreatic enzymes. It gets incorporated into chylomicrons, transported to the liver, and then repackaged into other lipoproteins like LDL for delivery to tissues. Red blood cells also carry some.
Who's particularly vulnerable to vitamin E deficiency? It doesn't seem as common as A or D deficiency.
True, overt deficiency is relatively uncommon in healthy individuals eating a varied diet. However, certain groups are at higher risk. Preterm infants are born with low vitamin E stores due to limited placental transfer, and their immature digestive systems may not absorb it well initially. They are particularly susceptible to hemolytic anemia if their formula is high in PUFAs but low in vitamin E.
Hemolytic anemia, breaking down red blood cells.
Yes, vitamin E protects red blood cell membranes from oxidative stress. Without enough E, the membranes become fragile and rupture easily, leading to anemia, jaundice, and an elevated reticulocyte count, immature red cells. Interestingly, giving iron supplements to a vitamin E deficient preemie can actually worsen the hemolysis.
What about older children or adults?
In older individuals, deficiency is almost always linked to conditions causing severe chronic fat malabsorption. This includes cholestatic liver disease, where bile flow is blocked, cystic fibrosis, short bowel syndrome, or rare genetic disorders like abetalipoproteinemia.
Abetalipoproteinemia, what's that?
It's a rare inherited disorder where individuals lack the ability to form chylomicrons and VLDL, lipoproteins needed for fat transport. This leads to severe malabsorption of all fats and fat-soluble vitamins, including vitamin E. Plasma levels are virtually undetectable.
What are the consequences?
These individuals develop a progressive neurological syndrome, usually starting in the first or second decade of life. It involves spinocerebellar ataxia, loss of coordination, peripheral neuropathy, loss of reflexes, vibration, and position sense, muscle weakness, and pigmented retinopathy, eye damage. It really highlights vitamin E's crucial role in maintaining nerve and muscle function.
Can treatment help in these cases?
Yes, administration of large oral doses of vitamin E is the mainstay of treatment for deficiency due to malabsorption. While it may not completely reverse existing damage, it can often halt progression and significantly ameliorate the neurological symptoms, especially if started early.
What about the other end? Hypervitaminosis E, is taking too much vitamin E dangerous?
Generally, vitamin E is considered one of the least toxic fat-soluble vitamins. Many adults take supplements containing 400–800 milligrams a day, which is many times the RDA, for long periods, apparently without harm.
So generally safe.
At moderately high doses, yes. Some studies have reported mild side effects like muscle weakness, fatigue, nausea, or diarrhea at very high doses, like 830–200 milligrams a day. The main concern with extremely high doses, typically over 1,000 milligrams a day, is potential interference with vitamin K function.
How does it interfere with vitamin K?
High doses of vitamin E can antagonize vitamin K's role in blood clotting, potentially increasing the risk of bleeding, especially in individuals who are already vitamin K deficient or are taking anticoagulant medications like warfarin. That interaction is the most significant toxicity risk.
That interaction brings us perfectly to our final fat-soluble vitamin. Vitamin K, the coagulation catalyst. Tell us about its forms and how it enables blood clotting.
Vitamin K exists naturally in two main forms. Vitamin K1, phylloquinone, which is found primarily in green leafy plants, and vitamin K2, methaquinones, which are a group of compounds synthesized by bacteria, including those in our own gut. There's also a synthetic form, K3, menadione.
And absorption, similar to the others.
Yes, being fat-soluble, its absorption from the upper small intestine requires bile salts and pancreatic enzymes. It's incorporated into chylomicrons, goes to the liver, which is the primary site of its action and storage, although body stores are relatively small compared to other fat-soluble vitamins.
What's its specific role in coagulation? How does it make blood clot?
Vitamin K's main physiological function is acting as an essential cofactor for a liver enzyme called gamma-glutamyl carboxylase. This enzyme modifies specific proteins by adding a carboxyl group, SAMI-OC, to some of their glutamic acid residues.
Making them gamma-carboxyglutamates.
Exactly. This modification is absolutely critical for several key blood coagulation factors, namely factors 2, prothrombin, 7X and X, as well as anticoagulant protein C and S.
Why is that modification so important?
Because those gamma-carboxyglutamate residues allow these proteins to bind calcium ions. This calcium binding is essential for the coagulation factors to anchor themselves properly to platelet phospholipids at the site of injury, enabling the whole coagulation cascade to proceed effectively and form a stable blood clot. Without vitamin K, these factors are produced, but they're inactive because they can't bind calcium or participate properly in clotting. So no K, no functional clotting factors, no clot. Given this critical role, I can see why newborns are particularly vulnerable, as you mentioned earlier in the context of breast milk.
They absolutely are. Newborn infants are at uniquely high risk for vitamin K deficiency for several reasons operating simultaneously. One, vitamin K transport across the placenta is very limited, so babies are born with low stores. Two, the newborn gut is initially sterile and takes time to establish the bacterial flora that produce vitamin K2. Three, breast milk, as we noted, is a relatively poor source of vitamin K1, polyquinone.
A perfect storm for deficiency.
It is. This combination of factors puts them at risk for vitamin K deficiency bleeding, VKDB, which used to be called hemorrhagic disease of the newborn, HDN.
When does VKDB typically occur?
It can occur in three forms.
Right.
Early, within 24 hours, often related to maternal medications like anticonvulsants that interfere with K, classic, day 2 to 7, primarily in breastfed infants not given prophylaxis, or late, 2 weeks to 6 months, again, mostly in exclusively breastfed infants, often presenting with dangerous intracranial bleeding.
And the symptoms?
Unexpected or excessive bleeding or bruising. This could be oozing from the umbilical sump or circumcision site, nosebleeds, blood in the stool or vomit, skin bruising, or most devastatingly, sudden intracranial hemorrhage. Lab tests show a markedly prolonged prothrombin time, PT, and often partial thromboplastin time, PTT, with a normal platelet count.
So prevention is absolutely key.
Absolutely essential. This is why routine prophylactic administration of vitamin K, usually 0.5, 1.0 milligram intramuscularly, to all newborns shortly after birth is a standard of care worldwide. It has dramatically reduced the incidence of classic and late VKDB. It's one of the most effective, simple public health interventions in neonatology.
Besides newborns, who else might become vitamin K deficient?
Deficiency can occur in older children or adults, usually due to secondary causes. Prolonged use of broad-spectrum antibiotics can wipe out gut flora, reducing K2 synthesis. Conditions causing fat malabsorption, biliary obstruction, cystic fibrosis, celiac disease, short bowel syndrome, impair K1 absorption. Chronic liver disease can impair both storage and the synthesis of clotting factors. And certain drugs, notably warfarin anticoagulants, directly antagonize vitamin K action. 3. Water-soluble vitamins, crucial coenzymes and their deficiency.
Okay, we've done a really deep dive into the fat-soluble vitamins A, D, E, and K. Now, let's pivot to the water-soluble vitamins. You mentioned the key difference is they're generally not stored except B12. What are the general characteristics and implications of this lack of storage?
That's the defining feature for most of them, yes. Because they're water-soluble, any excess intake beyond the body's immediate needs or a tissue saturation capacity is typically readily excreted via the kidneys into the urine.
So no long-term reserves building up?
Generally not. This means a continuous dietary supply is more critical compared to fat-soluble vitamins. Deficiencies can develop relatively quickly, sometimes in a matter of weeks or a few months, if the diet becomes consistently deficient.
But the flip side is lower toxicity risk.
Correct. Because the body efficiently gets rid of excess, toxicity, hypervitaminosis from high intakes, is much rarer and usually only occurs with extremely large supplemental doses of certain water-soluble vitamins, like niacin or B6.
And their main role is generally as coenzymes.
Yes, that's their primary mode of action. They, or their derivatives, act as coenzymes or cofactors that are essential helpers for hundreds of different enzymes involved in critical intracellular metabolic pathways, energy production, synthesis of amino acids and nucleic acids, neurotransmitter function, you name it. They are the catalysts that make the body's chemistry work efficiently.
Okay, let's go through some of the key players. Let's start with thiamine, vitamin B1, sometimes called the energy conductor. What's its core biological action, and what happens in deficiency?
Thiamine is absolutely fundamental for carbohydrate metabolism and cellular energy generation. Its active form, thiamine pyrophosphate, DPP, is a crucial coenzyme for several key enzymes involved in breaking down glucose to produce ATP, the cell's energy currency.
Which enzymes specifically?
Critical ones like pyruvate dehydrogenase, linking glycolysis to the citric acid cycle, and alpha-ketoglutarate dehydrogenase within the citric acid cycle itself. It's also involved in the pentose phosphate pathway, which makes NADPH and precursors for nucleic acid synthesis. Tissues with high energy turnover, like the brain, nerves, and heart, are particularly dependent on thiamine.
Where do we get thiamine?
Good sources include whole grains. It's mostly in the German brand, so polishing rice removes it. Legumes, nuts, pork, and fortified cereals or breads. Human milk and cow's milk contain it, but it's sensitive to heat processing like pasteurization or sterilization, and also to sulfites used as preservatives.
Deficiency leads to beriberi.
Yes, severe thiamine deficiency causes beriberi. Historically, this was common in populations relying heavily on polished white rice. Today, it's more often seen in individuals with chronic alcoholism. Alcohol impairs thiamine absorption and utilization, those with malnutrition, or sometimes after prolonged vomiting or IV feeding without proper supplementation.
You mentioned 3 forms earlier, dry, wet, and infantile.
That's right. Dry beriberi primarily affects the peripheral nervous system. It causes a symmetrical polyneuropathy, starting with tingling or burning in the feet, progressing to muscle weakness, wasting, loss of reflexes, and difficulty walking.
And wet beriberi.
Wet beriberi primarily affects the cardiovascular system. It leads to high-output heart failure with symptoms like rapid heartbeat, shortness of breath, enlarged heart, and significant edema, swelling, especially in the legs. It can be rapidly fatal if not treated.
And infantile.
Infantile beriberi occurs in breastfed infants whose mothers are thiamine deficient. It can have a very rapid, fulminant onset, often dominated by cardiac symptoms, heart failure, cyanosis, bluish skin, difficulty breathing, and a characteristic aphonia, voiceless cry. It can also present with neurological signs, again, potentially fatal within hours or days.
There's also Wernicke-Korsakoff syndrome. Is that related?
Yes, that's another manifestation of severe thiamine deficiency, most commonly seen in alcoholics, but can occur in other deficiency states. Wernicke encephalopathy is the acute phase, characterized by a classic triad of confusion: ophthalmoplegia, eye muscle paralysis, abnormal movements like nystagmus, and ataxia, gait disturbance. If not treated promptly with high-dose thiamine, it can progress to Korsakoff syndrome, which involves irreversible memory loss, amnesia, and confabulation, making up stories. It's a neurological emergency.
How is thiamine deficiency diagnosed and treated?
Diagnosis is often clinical, based on symptoms in a high-risk individual. It can be confirmed by measuring erythrocyte transcatolase activity, an enzyme eating TPP, before and after adding thiamine. A large increase indicates deficiency. Low urinary thiamine excretion also supports the diagnosis. Raised blood lactate and pyruvate can also occur. Treatment involves giving thiamine. Mild cases can use oral supplements, for example, 5-10 milligre a day. Severely ill patients, especially those with wet beriberi or Wernicke's, require intravenous or intramuscular thiamine, often in high doses, for example, 100 milligrams or more, initially, followed by oral maintenance. Response, particularly for cardiac symptoms, can be dramatically rapid, often within hours.
Remarkable how quickly it can respond. Okay, next, B vitamin, riboflavin, or vitamin B2, the redox facilitator. What's its function and what does deficiency look like?
Riboflavin is a central component of 2 major coenzymes: flavin adenine dinucleotide, FAD, and flavin mononucleotide, FMN. These flavin coenzymes are absolutely essential for a vast number of oxidation redox reactions throughout metabolism.
Redox reactions, like moving electrons around.
Oh, exactly. They are crucial electron carriers in the electron transport chain for ATP production, in fatty acid oxidation, the citric acid cycle, and many other pathways. Enzymes like glutathione reductase, important for antioxidant defense, also require FAD.
Where do we find riboflavin?
Good sources include milk and dairy products, eggs, meat, especially organ meats like liver, legumes, nuts, green leafy vegetables like broccoli, spinach, asparagus, and fortified cereals and breads. It's relatively heat-stable but sensitive to light, which is why milk is often sold in opaque containers.
And deficiency, what are the signs?
Riboflavin deficiency, sometimes called araboflavinosis, rarely occurs in isolation. It's usually part of a broader pattern of undernutrition. It typically takes a couple of months of poor intake to develop. The features are often related to skin and mucous membranes. Classic signs include chylosis, inflammation and cracking at the corners of the mouth, angular stomatitis, fissures at the angles of the lips, glossitis, a sore, smooth, purplish-red tongue, and seborrheic dermatitis, often affecting the nasolabial folds, eyelids, and scrotum. Eye symptoms like photophobia, light sensitivity, burning, itching, and corneal vascularization, blood vessels growing into the cornea, can also occur. Sometimes a normocytic anemia is seen.
How is it diagnosed and treated?
Diagnosis is usually based on the clinical picture and dietary history. It can be confirmed by measuring erythrocyte glutathione reductase activity coefficient, EGRAS, similar to the thiamine test, assessing enzyme activity with and without added FAD. Low urinary riboflavin excretion also indicates deficiency. Treatment is straightforward with oral riboflavin supplements, typically 3 to 10 milligrams per day for children, which usually resolves lesions fairly quickly.
Okay, moving on to niacin, vitamin B3, which protects against pellagra. What are its forms and how does it function?
Niacin refers to two related compounds, nicotinic acid and nicotinamide. Its crucial function is as a component of two vital coenzymes, nicotinamide adenine dinucleotide, NAD, and nicotinamide adenine dinucleotide phosphate, NADP.
NAD and NADP, those sound important.
They're absolutely central to metabolism.
Right.
Like the flavin coenzymes, FAD, FMN, NAD, and NADP are critical electron carriers involved in hundreds of redox reactions. NAD is particularly important in catabolic reactions that generate ATP, like glycolysis, citric acid cycle, fatty acid oxidation, while NADP is more involved in anabolic building reactions, like fatty acid and steroid synthesis, and also in antioxidant defense systems.
Can we make niacin ourselves?
Yes, uniquely among B vitamins, the body can synthesize niacin from the essential amino acid tryptophan. However, the conversion is quite inefficient. You need about 60 milligrams of tryptophan to make 1 milligram of niacin. So dietary intake of preformed niacin is still important.
Where do we get niacin or tryptophan?
Good sources of preformed niacin include meat, poultry, fish, enriched grains, legumes, and nuts. Foods rich in tryptophan, like milk, eggs, and most protein sources, also contribute to our niacin status. Niacin is relatively stable to heat and cooking.
Deficiency causes pellagra. What is that?
Yes, severe niacin deficiency leads to pellagra. The name comes from Italian pellagra, meaning rough skin. It's classically characterized by the 3 Ds, although a 4th D is often added: dermatitis, diarrhea, dementia, and potentially death if untreated.
Let's break those down. Dermatitis.
Pellagra causes a characteristic dermatitis, a symmetrical pigmented rash that develops on areas of skin exposed to sunlight, heat, or friction. It often looks like a severe sunburn initially, then becomes rough, thickened, and darkly pigmented. A classic pattern is the Kessel necklace, a broad collar-like rash around the neck.
Diarrhea.
Yes, gastrointestinal disturbances are common, including a sore mouth and tongue, similar to riboflavin deficiency, vomiting, abdominal pain, and persistent diarrhea, which can be watery or sometimes bloody.
And dementia.
Neurological symptoms are prominent in later stages. They can range from apathy, depression, fatigue, headache, and memory loss initially, progressing to confusion, disorientation, irritability, delirium, and eventually frank dementia. Peripheral neuropathy and spinal cord problems can also occur.
Who gets pellagra? Is it still common?
It used to be endemic in populations relying heavily on corn, maize, as a staple food, because the niacin in corn is largely bound in a form that's not bioavailable, and corn is also relatively low in tryptophan. It's much rarer now in developed countries due to food fortification and better diets, but it can still occur in severe malnutrition, chronic alcoholism, malabsorption syndromes, or with certain medications like isoniazid, which can interfere with B6 needed for tryptophan conversion. Heart and nut disease, a genetic disorder of tryptophan transport, also causes pellagra.
How is pellagra treated?
Treatment involves niacin supplementation, usually with nicotinamide, as high doses of nicotinic acid can cause flushing. Doses are typically much higher than the RDA, around 5,300 milligrams per day. Parenteral therapy might be needed initially if absorption is poor. Response is usually quite good if treated early, especially the dermatitis and diarrhea. Neurological symptoms may take longer or be partially irreversible if damage is severe. A balanced diet rich in protein and other B vitamins is also crucial.
Okay, next is pyridoxine, vitamin B6, another coenzyme player.
Yes, vitamin B6 encompasses several related compounds, pyridoxine, pyridoxal, pyridoxamine, that are all converted in the body to the active coenzyme form, pyridoxal phosphate, PLP. PLP is arguably one of the most versatile coenzymes, involved in over 100 different enzymatic reactions, predominantly in amino acid metabolism.
Amino acid metabolism, like what?
Things like transamination, moving amino groups, decarboxylation, removing carboxyl groups, important for making neurotransmitters like serotonin, dopamine, GABA, heme synthesis for hemoglobin, glycogen metabolism, and the conversion of tryptophan to niacin. It's incredibly busy.
Sources of B6.
It's widely distributed in foods. Good sources include meat, poultry, fish, whole grains, fortified cereals, legumes, nuts, potatoes, bananas, and spinach.
Is deficiency common?
Primary dietary deficiency is relatively rare in developed countries. When it occurs, it's often associated with alcoholism, certain medications, like isoniazid for TB, hydrolysine, penicillamine, or malabsorption syndromes. Infants fed improperly prepared formula lacking B6 have developed seizures.
What are the signs of deficiency?
Symptoms can be varied due to PLP's widespread roles. Neurological issues are common, including peripheral neuropathy, numbness, tingling in hands, feet, irritability, depression, confusion, and in severe cases, seizures, especially in infants, often refractory to standard anticonvulsants. Skin changes like seborrheic dermatitis and goitre, similar to B2 and B3 deficiency, can occur. A specific type of microcytic hypochromic anemia, sideroblastic anemia, can also result because PLP is needed for heme synthesis. Elevated homocysteine levels are also seen.
How is B6 deficiency treated?
Treatment is with pyridoxine supplementation. Doses vary depending on the cause and severity. For example, patients taking isoniazid acid are routinely given 10-50 mg a day prophylactically to prevent neuropathy. Higher doses, sometimes up to 100 mg intramuscularly, might be needed to treat refractory seizures in infants. There are also rare genetic conditions of B6 dependency that require lifelong high-dose supplementation.
Okay, now for biotin, the one linked to raw eggs.
Yes, the raw egg white story. Biotin is another B vitamin that acts as a crucial coenzyme, specifically for carboxylase enzymes. These enzymes add a carboxyl group to various molecules and are essential for fatty acid synthesis, amino acid metabolism, and gluconeogenesis, making glucose.
And the raw egg connection.
Raw egg whites contain a protein called avidin, which binds biotin very tightly in the gut, preventing its absorption. Consuming large quantities of raw eggs over a long period, months, can induce biotin deficiency. Cooking eggs denatures avidin, so cooked eggs pose no problem.
Is that the only cause of deficiency?
No, it's actually quite rare overall. Biotin deficiency can also occur with long-term total parenteral nutrition, TPN, without biotin supplementation in certain malabsorption states, or due to rare genetic disorders affecting biotin metabolism, like biotinidase deficiency or holocarboxylase synthetase deficiency, multiple carboxylase deficiency. These genetic forms present early in infancy with severe symptoms.
What are the symptoms of biotin deficiency?
They often involve the skin and hair. A characteristic scaly red dermatitis, often around the eyes, nose, and mouth, is common. Hair loss, alopecia, can also occur. Neurological symptoms like lethargy, depression, hallucinations, and numbness tingling can develop. Infants with genetic disorders often have seizures, hypotonia, and developmental delay. Metabolic acidosis and organic aciduria are also seen.
Sources and treatment.
Biotin is found in many foods, particularly liver, egg yolk, cooked, nuts, legumes, and whole grains. It's also produced by gut bacteria, which contributes to our supply. Deficiency is treated with oral biotin supplements, usually 5-10 mg a day. The genetic disorders often respond dramatically to pharmacological doses of biotin.
Next, pantothenic acid, vitamin B5. You called it ubiquitous earlier.
Yes, pantothenic acid gets its name from the Greek word pantos, meaning everywhere, because it's found in virtually all plant and animal tissues. This widespread distribution makes isolated dietary deficiency extremely rare in humans.
Oh, what does it do?
Its critical function is as a component of coenzyme A, CoA. CoA is absolutely central to energy metabolism. It's involved in the citric acid cycle, fatty acid oxidation, fatty acid synthesis, cholesterol synthesis, acetylcholine synthesis. The list goes on. It acts as a carrier for acyl groups, like the acetyl group in acetyl-CoA.
Yeah.
It's also part of acyl carrier protein, ACP, needed for fatty acid synthesis.
So, fundamental to metabolism, if deficiency is rare, have symptoms ever been described?
Yes. Deficiency has been experimentally induced in volunteers or observed in severely malnourished populations, like prisoners of war. Symptoms are generally nonspecific and may include fatigue, headache, sleep disturbances, nausea, abdominal cramps, and numbness or tingling in the hands and feet, sometimes called burning feet syndrome. But again, isolated deficiency is almost never seen clinically. Standard multivitamin supplements usually provide adequate amounts.
Okay, now for a really important one. Cobalamin, vitamin B12, known for long-term storage and its role in myelin and nerves.
Absolutely. Vitamin B12, or cobalamin, is a large, complex vitamin containing the mineral cobalt. The active coenzyme forms in humans are methylcobalamin and 5-foot-deoxydenacylcobalamin. Cyanocobalamin is the stable form often used in supplements and fortification.
What are its key functions?
It serves as a cofactor for only 2 known enzymatic reactions in humans, but they are critically important. 1. Methionine synthase. This enzyme uses methylcobalamin to convert homocysteine to methionine, an essential amino acid. This reaction is also crucial for regenerating tetrahydrofolate, the active form of folate needed for DNA synthesis.
Yeah.
2. Methylmalonyl-CoA nutase. This enzyme uses adenosylcobalamin to convert methylmalonyl-CoA to succinyl-CoA, a step in the breakdown of certain fatty acids and amino acids.
So, involved in DNA synthesis via folate and also fat protein breakdown. Where does B12 come from? Can plants make it?
No, this is key. Vitamin B12 is synthesized only by microorganisms, bacteria and archaea. Plants do not produce it. Therefore, dietary B12 comes exclusively from animal-derived foods, meat, poultry, fish, eggs, and dairy products. Liver and shellfish, like clams and oysters, are particularly rich sources.
So strict vegetarians or vegans are at risk?
Yes, vegans who consume no animal products at all are at high risk of deficiency unless they take B12 supplements or consume B12 fortified foods, like fortified cereals, plant milks, or nutritional yeast.
Absorption is complex too, right? Involving intrinsic factor.
Extremely complex and fascinating. When you eat B12, it first gets released from food proteins by stomach acid and pepsin. Then it binds to a protein called R-binder. In the duodenum, pancreatic enzymes release B12 from R-binder, and it then binds tightly to intrinsic factor, IF, a glycoprotein secreted by parietal cells in the stomach lining.
And IF is the key.
IF is the essential chaperone. The B12-IF complex travels down to the terminal ileum, the last part of the small intestine, where specific receptors on the intestinal cells recognize and bind the complex, allowing B12 to be absorbed into the bloodstream. It's then transported bound to proteins called transcobalamins.
So problems anywhere along that path can cause deficiency.
Absolutely. Lack of stomach acid, lack of intrinsic factor due to autoimmune gastritis causing pernicious anemia or after stomach surgery, lack of pancreatic enzymes or diseases affecting the terminal ileum like Crohn's disease, ileal resection, can all impair B12 absorption and lead to deficiency.
How long do body stores last? You mentioned it's an exception to the water-soluble rule.
Right. Unlike most water-soluble vitamins, the body stores a significant amount of B12, primarily in the liver. Total body stores can be 2 to 5 milligrams, which is enough to last for several years, typically 3 to 5 years, even if absorption completely stops. This is why deficiency often develops very gradually. There's also an enterohepatic circulation that helps conserve B12.
What are the consequences of B12 deficiency?
The consequences are serious, affecting both the blood and the nervous system. The impairment of methionine synthase leads to a buildup of homocysteine and, crucially, traps folate in an unusable form. This disrupts DNA synthesis, especially in rapidly dividing cells like blood cell precursors in the bone marrow.
Leading to anemia.
Yes, it causes megaloblastic anemia, characterized by abnormally large immature red blood cells, macrocytes, and hypersegmented neutrophils seen on a blood smear. Platelet and white blood cell counts can also be low. Symptoms of anemia include fatigue, weakness, shortness of breath, and pale skin.
And the neurological problems. Those sound particularly severe.
They are the most concerning aspect. B12 deficiency causes progressive demyelination damage to the myelin sheath that insulates nerve fibers. This can affect peripheral nerves, the spinal cord, leading to subacute combined degeneration, and the brain.
Why does B12 deficiency cause nerve damage?
The exact mechanisms aren't fully understood, but it likely involves the disruption of methionine synthase, affecting methylation reactions needed for myel maintenance, and the buildup of methylmalonic acid due to impaired methylmalonyl-CoA mutase, which might be directly toxic to myelin.
What are the neurological symptoms?
They often start subtly with symmetrical numbness and tingling in the hands and feet, paresthesias, loss of vibration and position sense, unsteadiness, and weakness. It can progress to spasticity, cognitive impairment, memory loss, confusion, dementia, depression, and even psychosis. Importantly, neurological symptoms can occur even without anemia or before anemia develops.
That's critical nerve damage without the blood signs. How is deficiency diagnosed?
Diagnosis involves measuring serum B12 levels. Levels below 150-200 pg/ml are typically considered deficient. However, levels in the low normal range can sometimes be associated with metabolic deficiency. Therefore, measuring methylmalonic acid, MMA, and plasma homocysteine levels is often recommended. Both MMA and homocysteine are typically elevated in B12 deficiency, whereas only homocysteine is elevated in folate deficiency. Identifying the cause of deficiency, for example, pernicious anemia via anti-IAPF antibodies, is also important.
And treatment, especially given the nerve damage risk.
Treatment involves replenishing B12 stores, usually with intramuscular or subcutaneous injections of cyanocobalamin or hydroxycobalamin. A typical regimen might be 1,000-gram injections daily or weekly initially, followed by monthly injections for life if the cause of malabsorption cannot be corrected. High-dose oral B12, 1,000-2,000 ORD, can also be effective even in pernicious anemia, as a small amount can be absorbed passively without IF. Nasal sprays are also available.
You mentioned a critical warning earlier about treating megaloblastic anemia before ruling out B12 deficiency. Can you reiterate that?
Yes, this is absolutely vital. If a patient has megaloblastic anemia,
It could be due to either folate or B12 deficiency. If you give folic acid to someone who is actually B12 deficient, the anemia might improve temporarily. The hematological picture might get better, but the folic acid will not correct the underlying B12 deficiency, causing the neurological damage. In fact, by masking the anemia, it can allow the neurological damage to progress unchecked and potentially become irreversible. So rule number 1, always check B12 status before giving folate for megaloblastic anemia.
Always exclude, and if necessary, treat B12 deficiency first or concurrently. It's a critical safety point.
Got it. Okay, that leads us perfectly to folic acid, the other key player in megaloblastic anemia and DNA building. What is it exactly?
Folic acid itself, taurine monoglutamic acid, is the synthetic oxidized form found in fortified foods and supplements. Naturally occurring forms in food are called folates, taurine polyglutamates, which are more complex and less stable. Both are converted in the body to the active coenzyme form tetrahydrofolate, THF.
And THF's function. THF and its derivatives are essential coenzymes for one-carbon metabolism. They transfer single carbon units, like methyl formyl groups, in various critical reactions, most importantly in the synthesis of purines and pyrimidines, the building blocks of DNA and RNA. They are also involved, along with B12, in converting homocysteine to methionine. So like B12, folate is absolutely crucial for DNA synthesis and cell division.
Where do we get folate?
The name comes from folium, Latin for leaf, because leafy green vegetables, spinach, turnip greens, lettuce, broccoli, asparagus, are excellent sources. Other good sources include legumes, beans, peas, lentils, fruits, especially citrus fruits and berries, nuts, liver, and importantly, fortified grain products. Many countries mandate folic acid fortification of flour and cereals,
Why the fortification?
primarily to prevent neural tube defects, NTDs, in newborns.
Ah, yes. Tell us about that connection.
Adequate folate intake, especially in the very early stages of pregnancy, often before a woman even knows she's pregnant, is critical for the proper closure of the neural tube, which develops into the baby's brain and spinal cord. Insufficient folate status during this periconceptional period significantly increases the risk of NTDs like spina bifida and anencephaly.
So fortification helps ensure women have adequate levels before conception.
Exactly. Since NTDs form so early, within the first 28 days, waiting until pregnancy is confirmed is often too late. Fortification provides a background level, and health authorities universally recommend that all women capable of becoming pregnant consume 400 micrograms of synthetic folic acid daily from supplements or fortified foods, in addition to dietary folate. Women with a previous NTD pregnancy need much higher doses under medical guidance.
Besides pregnant women, who else is at risk for folate deficiency?
Deficiency can occur due to inadequate intake, poor diet lacking fresh produce, malabsorption syndromes like celiac disease, inflammatory bowel disease, conditions with increased requirements like pregnancy and lactation, chronic hemolytic anemias where red cell turnover is high, certain skin diseases, and certain medications that interfere with folate metabolism like methotrexate, some anticonvulsants like phenytoin, trimethoprim. Alcoholism also contributes. Preterm infants are also at risk due to low stores and high demands.
What are the signs of folate deficiency besides NTDs?
The main consequence, similar to B12 deficiency, is megaloblastic anemia due to impaired DNA synthesis, affecting rapidly dividing cells in the bone marrow. Symptoms are typical of anemia. Fatigue, weakness, shortness of breath, pallor, glossitis, sore tongue, and diarrhea can also occur. Unlike B12 deficiency, folate deficiency generally does not cause the characteristic neurological damage, subacute combined degeneration. Homocysteine levels are elevated, but MMA levels remain normal.
How is it treated?
Treatment involves oral folic acid supplementation, typically 0.5 to 1 milligram per day, or higher in malabsorption. Response is usually rapid, with reticulocytosis, increase in young red cells within days, and correction of anemia over weeks. And again, the crucial caveat: always ensure B12 deficiency is ruled out or treated concurrently before giving folate for megaloblastic anemia.
Right, that warning bears repeating. Okay, our final water-soluble vitamin, vitamin C, L-ascorbic acid, or ascorbate, the connective tissue guardian, famously linked to scurvy. What are its functions?
Vitamin C is a water-soluble vitamin with several vital functions, primarily acting as a potent reducing agent and antioxidant. Its most well-known role is being essential for the synthesis of collagen.
Collagen, the main protein in connective tissue.
Exactly. Vitamin C is a required cofactor for enzymes, polyol and lysyl hydroxylases, that hydroxylate proline and lysine residues during collagen formation. This hydroxylation step is crucial for stabilizing the collagen triple helix structure. Without adequate vitamin C, collagen is unstable, leading to fragile tissues.
So that explains its importance in wound healing and blood vessel integrity.
Absolutely. It's critical for maintaining normal connective tissue, blood vessel walls, skin, gums, and bone matrix, osteoid formation.
Yeah.
It's also involved in the synthesis of carnitine, needed for fatty acid transport, neurotransmitters like norepinephrine, and enhances the absorption of non-heme iron from plant foods in the gut by reducing ferric iron, Fe3+, to the more absorbable ferrous form, Fe2+. As an antioxidant, it helps protect cells from oxidative damage and regenerates other antioxidants like vitamin E.
Can humans make vitamin C?
No, unlike most mammals, humans, along with other primates, guinea pigs, and bats, lack the final enzyme in the synthesis pathway, guanylactone oxidase. Therefore, vitamin C is an essential nutrient that must be obtained from the diet.
Where do we find it?
The richest sources are fresh fruits and vegetables. Citrus fruits, oranges, lemons, limes, grapefruit, berries, strawberries, raspberries, kiwi fruit, cantaloupe, tomatoes, peppers, especially red bell peppers, broccoli, Brussels sprouts, cabbage, cauliflower, spinach, and potatoes are all good sources.
Is it stable? Does cooking destroy it?
Vitamin C is quite sensitive to heat, oxygen, and light, and it leaches into cooking water. So, prolonged cooking, high temperatures, and extensive storage can significantly reduce the vitamin C content of foods. However, it's relatively stable in acidic conditions and in canned or frozen foods if processed properly. Raw or lightly steamed fruits and vegetables are generally the best sources. Human milk contains adequate C if the mother's intake is sufficient. Cow's milk is a poor source, and boiling it destroys what little C is present.
What are the daily requirements?
The RDA for adults is 75 mg a day for women and 90 mg a day for men. Smokers need an additional 35 mg a day due to increased oxidative stress. Requirements are higher during pregnancy and lactation. Infants and children have lower requirements based on age.
Deficiency leads to scurvy. What does that look like?
Scurvy develops after several weeks to months of severe vitamin C deprivation. It's primarily due to defective collagen synthesis, leading to widespread capillary fragility and impaired connective tissue integrity.
What are the early signs?
Early symptoms can be nonspecific: fatigue, malaise, irritability, loss of appetite, weight loss, and vague muscle or joint aches. Small pinpoint hemorrhages around hair follicles, parafollicular petechia, especially on the legs, are often an early characteristic sign. Easy bruising also occurs.
And the classic, more severe features.
As it progresses, the signs become more dramatic. Gingival disease is classic. Gums become swollen, spongy, purple, and bleed easily. Teeth may loosen and fall out. Bleeding can occur elsewhere into the skin, large bruises or ecchymoses. Muscles, causing pain and swelling. Joints, hemarthrosis, leading to painful swollen joints. And under the periosteum of bones, superiosteal hemorrhage, causing intense bone pain, especially in infants and children. Children may adopt a characteristic frog leg posture due to limb pain and refuse to move, pseudoparalysis.
What about wound healing?
Wound healing is significantly impaired. Old scars may break down. Anemia often develops due to blood loss and possibly impaired iron absorption metabolism. In severe untreated scurvy, death can occur from massive hemorrhage, like cerebral or pericardial bleeding or infection.
How is scurvy diagnosed?
Diagnosis is usually based on the characteristic clinical findings in the context of a dietary history, suggesting inadequate vitamin C intake. GHAI, diet lacking fresh fruits, vegetables, reliance on boiled milk in infants, severe dietary restrictions. Plasma ascorbate levels can be measured and will be very low, but clinical signs are key. X-rays of long bones in children can show characteristic changes related to superiosteal bleeding and abnormal mineralization at the metaphysis. For example, white line of Frankel, Trommerfeld zone, Pelkin spurs, Wimberger ring sign.
How is it treated?
Treatment is simple and remarkably effective. Vitamin C supplementation. Oral doses of 100 to 200 milligrams per day for adults, lower for children, lead to rapid improvement, often within days for bleeding gums and pain, although full recovery takes weeks. Ensuring a diet rich in vitamin C sources prevents recurrence. Consuming citrus juice or fresh vegetable pulp daily has the same effect. Essential minerals, the body's structural and functional foundations.
Okay, we've covered all the vitamins, both fat-soluble and water-soluble, in incredible detail. Now let's turn our final focus to the essential minerals, the body's structural and functional foundations. Can you briefly recap their general roles again?
Certainly. As we touched on earlier, minerals are inorganic elements essential for life. We distinguish between major minerals, like calcium, phosphorus, magnesium, sodium, potassium, chloride, sulfur, which are needed in larger amounts, typically 100 milligrams per day, and trace minerals like iron, zinc, copper, iodine, selenium, manganese, chromium, molybdenum, fluoride, needed in much smaller quantities, 100 milligrams a day.
Some are needed in even tinier amounts, the ultra-trace minerals.
And their functions are diverse.
Incredibly diverse. They provide structural components like calcium and phosphorus in bone, maintain fluid and electrolyte balance, sodium, potassium, chloride, act as cofactors for hundreds of enzymes, zinc, magnesium, copper, manganese, selenium, carry oxygen, iron, facilitate nerve impulse transmission and muscle contraction, sodium, potassium, calcium, magnesium, and regulate hormone function, iodine. They are fundamental to almost every bodily process.
Let's start with calcium, the most abundant mineral, known as the bone and nerve commander. Beyond bone structure, what are its key functions and how is absorption regulated?
Right. Calcium is the most abundant mineral, with about 99% residing in our bones and teeth, providing hardness and strength. But that remaining 1% circulating in body fluids or within cells is absolutely critical for vital physiological functions.
It's such as?
It's essential for blood coagulation, as we saw with vitamin K, nerve impulse transmission, release of neurotransmitters, muscle contraction, both skeletal and smooth muscle, hormone secretion, and activating various enzymes. Maintaining precise control over blood calcium levels is therefore paramount.
How is absorption controlled? You mentioned active vitamin D earlier.
Yes, intestinal calcium absorption is tightly regulated, primarily by the active form of vitamin D, calcitriol, 1025-OH2D. Calcitriol stimulates the synthesis of calcium-binding proteins like calbindin in intestinal cells, which facilitates calcium transport from the gut into the bloodstream. Absorption efficiency adapts. It increases when dietary intake is low or during periods of high need, like growth, pregnancy, lactation, and decreases when intake is high.
What affects absorption besides vitamin D?
Several dietary factors can influence it. High intake of phytates, found in whole grains, legumes, seeds, and oxalates in spinach, rhubarb, nuts, can bind calcium in the gut and reduce its absorption. High fiber intake might also slightly decrease absorption. On the other hand, lactose, milk, sugar, may enhance absorption in infants. Fat intake doesn't directly impact calcium absorption much, unlike fat-soluble vitamins.
Main sources. Milk and dairy are the obvious ones.
Yes, milk, yogurt, and cheese are major sources, especially for infants and children, providing highly bioavailable calcium. Once solids are introduced, fortified foods, cereals, juices, green leafy vegetables, though bioavailability varies due to oxalates, c.g. better from kale and broccoli than spinach, canned fish with bones, like sardines, salmon, legumes, nuts, and seeds also contribute.
What happens with calcium deficiency?
Acute severe deficiency, hypocalcemia, causes increased neuromuscular excitability, leading to tetany characterized by muscle cramps, especially hands, feet, carpal tunnel spasm, numbness and tingling around the mouth and extremities, and potentially seizures or laryngospasm. Chronic inadequate calcium intake contributes significantly to poor bone mineralization, leading to rickets in children and increased risk of osteoporosis and fractures in adults.
Recommended intake varies.
Yes, needs are highest during periods of rapid bone growth infancy, childhood, and especially the pubertal growth spurt. Requirements are also increased during pregnancy and lactation. Ensuring adequate intake during these critical periods is vital for achieving optimal peak bone mass.
Okay, next mineral. Magnesium, the enzyme activator. What are its main functions and sources?
Magnesium is another crucial mineral, involved as a cofactor or activator in over 300 enzymatic reactions. It's essential for energy metabolism, ATP production and utilization, protein synthesis, nucleic acid synthesis, muscle contraction, nerve function, blood glucose control, and blood pressure regulation. It also plays a structural role in bone.
Where is it found in the body?
About 50–60% of body magnesium is stored in bone, with most of the rest inside cells, particularly in skeletal muscle. Only about 1% is in the extracellular fluid.
Good dietary sources.
Magnesium is abundant in plant foods. Legumes, beans, lentils, nuts, almonds, cashews, seeds, pumpkin, chia, whole grains, brown rice, oats, and green leafy vegetables. Soonish chlorophyll contains magnesium. Bananas, avocados, and dark chocolate are also decent sources. Animal products contain less.
How is it regulated?
Absorption occurs mainly in the small intestine. The kidneys play the major role in regulating magnesium balance by adjusting urinary excretion based on body needs and intake.
Is deficiency common?
Overt deficiency is uncommon in healthy people eating a varied diet, but suboptimal intake might be more widespread. Deficiency is more likely in certain conditions. Gastrointestinal diseases causing malabsorption or excessive losses, chronic diarrhea, Crohn's, celiac, bowel resection, chronic alcoholism, type 2 diabetes due to increased urinary loss, and with the use of certain medications like diuretics, proton pump inhibitors. It's also common in severely malnourished children. Protein energy malnutrition.
What are the symptoms of deficiency, hypomagnesemia?
Early signs can be nonspecific, loss of appetite, nausea, vomiting, fatigue, weakness. As deficiency worsens, neurological symptoms appear. Numbness, tingling, muscle cramps, seizures, personality changes, abnormal heart rhythms, arrhythmias. Hypomagnesemia often coexists with and can worsen hypocalcemia and hypokalemia, low potassium.
Requirements for magnesium.
RDAs vary by age and sex, generally increasing through childhood and adolescence. Adults typically need around 300–420 milligrams a day.
All right, let's talk about zinc, the growth and immunity catalyst. Second most common trace element after iron, you said.
Yes. After iron, zinc is the most abundant trace element in the body, and its functions are incredibly diverse and essential. It's a component or cofactor for over 200, possibly over 300, different enzymes involved in virtually all aspects of metabolism.
What kind of enzymes?
Enzymes involved in carbohydrate, protein, lipid, and nucleic acid metabolism. It's crucial for DNA and RNA synthesis, protein synthesis, cell division, and growth. This is why it's so important during childhood and adolescence. It's also a structural component of many proteins, including zinc finger proteins, which are critical for regulating gene expression.
And immunity.
Yes, zinc plays a vital role in immune function development and function of immune cells like T lymphocytes. It's also important for wound healing, taste perception, vision, part of enzymes in the retina, and antioxidant defense as a component of superoxide dismutase.
Where do we get zinc?
The best dietary sources are animal proteins. Red meat, poultry, oysters, extremely rich, shellfish, fish, eggs, dairy products. Zinc from animal sources is generally better absorbed than from plant sources.
Why is plant zinc less available?
Because plant foods like whole grains, legumes, nuts, and seeds also contain phytates, phytic acid. Phytates strongly bind zinc in the gut, forming insoluble complexes and significantly inhibiting its absorption. This means diets high in unrefined grains and legumes, but low in animal protein put people at higher risk of deficiency. Leavening bread, using yeast, helps break down phytates and improves zinc absorption.
How is zinc absorbed and regulated?
Absorption occurs primarily in the small intestine via specific transporter proteins. It's regulated based on body needs. Absorption increases when stores are low and decreases when they're sufficient. Zinc homeostasis is also maintained by regulating excretion, mainly via feces through intestinal secretions rather than urine. There isn't a large functional storage pool like iron has ferritin.
Who is most at risk for zinc deficiency?
Groups with increased requirements are at risk: infants, children, adolescents, due to rapid growth, and pregnant and lactating women. Also, individuals with inadequate intake, especially those on high phytate, low animal protein diets, malabsorption syndromes, Crohn's, celiac, short bowel, chronic diarrhea leading to excessive fecal losses, chronic liver or kidney disease, sickle cell disease, alcoholism, and potentially older adults and strict vegetarians. Prolonged intravenous feeding without adequate zinc is another cause.
What are the clinical features of deficiency?
Zinc deficiency can manifest in many ways. Key features include growth retardation, stunting in infants and children, delayed sexual maturation and hypogonadism in adolescents, impaired immune function leading to increased susceptibility to infections, particularly diarrhea and pneumonia, diarrhea itself, skin lesions, dermatitis, often around orifices and extremities, alopecia, hair loss, impaired wound healing, loss of appetite, anorexia, altered taste or smell, night blindness, and behavioral changes like lethargy or irritability.
You mentioned acrodermatitis enteropathica earlier in relation to zinc.
Yes, that's a rare, inherited autosomal recessive disorder causing severe zinc deficiency due to a defect in a specific zinc transporter protein, the IP4, in the intestine, leading to profoundly impaired zinc absorption.
What does it look like?
It typically presents in early infancy, often shortly after weaning from breast milk, which contains zinc bound to a ligand that aids absorption. Symptoms are dramatic: severe vesicobulous, blistering, pustular or dry, scaly, eczematous skin lesions, characteristically located around the mouth, eyes, anus, periorificial, and on the hands and feet, acral areas. Severe diarrhea, alopecia, eye inflammation, conjunctivitis, blepharitis, growth failure, irritability, and recurrent infections are also hallmarks.
How is it treated?
Fortunately, ectodermatitis enteropathica responds completely and dramatically to lifelong oral zinc supplementation. It's a classic example highlighting zinc's critical roles.
How is milder zinc deficiency diagnosed and treated?
Diagnosing marginal zinc deficiency can be tricky, as plasma or serum zinc levels aren't always reliable indicators of tissue status. Diagnosis often relies on a combination of dietary assessment, clinical signs consistent with deficiency, and sometimes measuring zinc in hair or response to supplementation. Treatment of acquired deficiency involves oral zinc supplements, typically 0.5–1.0 milligrams of elemental zinc per kilograms per day. Higher doses might be used initially for malnourished children with diarrhea. Note: zinc sulfate, acetate, gluconate salts contain different percentages of elemental zinc.
Okay, next trace mineral, copper, the oxidative metabolism assistant. What does copper do?
Copper is another essential trace mineral that functions primarily as a component of several critical metalloenzymes, many of which were involved in oxidative metabolism and utilizing iron. These are called cuproenzymes. Key examples include cytochrome C oxidase, the final enzyme in the electron transport chain essential for ATP production, ceruloplasmin, involved in iron transport and metabolism, superoxide dismutase, an antioxidant enzyme along with zinc, lysyl oxidase, needed for cross-linking collagen and elastin in connective tissue, dopamine beta-hydroxylase, neurotransmitter synthesis, and tyrosinase, melanin pigment formation.
How is copper absorbed and transported?
Copper is absorbed mainly in the stomach and upper small intestine. It's transported to the liver, where it's incorporated into ceruloplasmin. Ceruloplasmin is the main copper-carrying protein in the blood and delivers copper to peripheral tissues. Excess copper is primarily excreted through bile into the feces. Very little is lost in urine.
Good sources of copper.
The richest sources are organ meats, especially liver, shellfish, oysters, nuts, cashews, seeds, sunflower, legumes, and whole grains. Chocolate and mushrooms also contain copper. Drinking water can sometimes contribute if it flows through copper pipes.
Is deficiency common?
Primary dietary deficiency is relatively infrequent. When deficiency occurs, it's usually secondary to other conditions. Prematurity, infants are born with low stores. Severe malnutrition, malabsorption syndromes, prolonged TPN without copper, excessive zinc intake, high zinc interferes with copper absorption, or after bariatric surgery.
What are the consequences of copper deficiency?
Copper deficiency affects several systems. Hematologically, it causes a microcytic hypochromic anemia that looks like iron deficiency but is unresponsive to iron therapy. This is because copper, in ceruloplasmin, is needed to mobilize iron from stores. Neutropenia, low white blood cell count, is also a very common and early sign. Neurological problems can be severe, mimicking B12 deficiency, myelopathy, peripheral neuropathy, optic neuropathy. Bone abnormalities, osteoporosis, fractures, hair depigmentation, steely hair, and impaired immunity can also occur.
Are there genetic disorders of copper metabolism?
Yes, two major inherited disorders involve disrupted copper transport. Wilson disease is an autosomal recessive disorder where excess copper accumulates in the liver, brain, and other tissues due to impaired biliary excretion, leading to liver damage and neurological problems. Menck disease, which you mentioned earlier, is a rare, X-linked fatal disorder caused by impaired absorption and cellular transport of copper. It leads to severe systemic copper deficiency.
What does Menck disease look like?
It presents in early infancy with severe neurological regression, seizures, hypotonia, failure to thrive, characteristic kinky or steely hair, brittle, sparse, twisted, often lightly pigmented, and pale, doughy skin. Lab findings show very low serum copper and ceruloplasmin. It's generally fatal in early childhood. It tragically highlights copper's essentiality for brain development and connective tissue.
Very different from Wilson disease's copper overload. Okay, let's move to selenium, the antioxidant and thyroid regulator.
Selenium is a trace element whose importance has been recognized more recently. Its primary function is as an essential component of a small number of specific proteins called selenoproteins.
What do these selenoproteins do?
The most well-known are the glutathione peroxidases, GPX, which are powerful antioxidant enzymes that work with vitamin E to protect cell membranes from oxidative damage by breaking down harmful peroxides. Another key group are the iodothyronine deiodinases, enzymes required to convert the thyroid hormone thyroxine T4 into its more active form, triiodothyronine T3. Selenium is also important for normal immune function and reproductive health.
Sources of selenium.
Selenium content in foods varies greatly depending on the selenium content of the soil where plants were grown or animals were raised. Generally, good sources include seafood, organ meats, muscle meats, eggs, grains, especially whole grains, and dairy products. Brazil nuts are exceptionally high in selenium.
Deficiency states. Are they common?
Overt selenium deficiency is rare in most parts of the world, but it occurs in areas with very low soil selenium content, notably parts of China, where it was linked to Keyshawn disease.
Keyshawn disease.
Yes, Keyshawn disease is an endemic cardiomyopathy, heart muscle disease, primarily affecting young children and women of childbearing age in selenium-deficient regions. It's thought that selenium deficiency makes the heart more susceptible to damage from certain viruses or other stresses. Supplementation prevents it.
Any other deficiency links?
In some parts of Africa, combined severe deficiency of both selenium and iodine has been implicated in a particularly severe form of endemic cretinism, myxedematous cretinism, associated with hypothyroidism. Deficiency can also occur in patients on long-term TPN without selenium or with severe malabsorption. Manifestations might include muscle weakness or pain, cardiomyopathy, nail changes, whitening, hair changes, loss of pigment, and potentially impaired immunity or thyroid function.
Interesting link with iodine. Let's touch briefly on chromium. Its role seems linked to glucose.
Yes, chromium is a trace element believed to play a role in carbohydrate and lipid metabolism. It's thought to potentiate the action of insulin, possibly by facilitating insulin binding to its receptor, thereby helping to maintain normal glucose tolerance.
Is deficiency a concern?
The essentiality and precise functions of chromium are still debated, and overt deficiency is considered very rare. It has primarily been described in patients receiving long-term TPN lacking chromium who developed glucose intolerance, weight loss, and peripheral neuropathy that responded to chromium supplementation. Evidence for benefits of chromium supplements in people with diabetes or for weight loss is generally weak or inconsistent. Good food sources include whole grains, brewer's yeast, nuts, broccoli, and meat.
Okay, now for a hugely important mineral globally, iodine, the brain development essential. What's its function?
Iodine's sole confirmed physiological function is an essential component of the thyroid hormones, thyroxine T4 and triiodothyronine T3, produced by the thyroid gland. Each molecule of T4 contains 4 iodine atoms, and T3 contains 3.
And thyroid hormones are crucial for.
Thyroid hormones regulate the metabolic rate of most cells and play absolutely critical roles in normal growth and development, particularly the development of the brain. The fetal brain and the brain during the first few years of postnatal life are exquisitely dependent on adequate thyroid hormone levels for normal maturation, myelination, and synaptogenesis.
So iodine is essential for making the hormones essential for brain development. Where do we get iodine?
The primary natural source of iodine is the ocean. Therefore, seafood, fish, shellfish, seaweed is generally rich in iodine. Plants grown in coastal areas or areas with iodine-rich soil also contain iodine. However, soil iodine content varies greatly. Inland and mountainous regions, especially those subject to glaciation or heavy rainfall, which leaches iodine from the soil, are often severely iodine deficient. Areas like the Himalayas, Andes, Alps, and large parts of Central Africa and Asia are classic endemic deficiency zones.
Is table salt a source?
Yes, iodized salt is the major source of iodine for most populations worldwide today. The strategy of fortifying salt with iodine has been incredibly successful in preventing iodine deficiency disorders. Dairy products can also be a source, partly due to iodine used in sanitizers in the dairy industry and sometimes in cattle feed.
What are the recommended intakes?
The RDA for adults is 150 micrograms day. Needs increase significantly during pregnancy to 220 oing day and lactation to 290 oing day to ensure adequate hormone production for both mother and the developing fetus infant. Infants and children need 90-120 oing day depending on age.
How is iodine status assessed?
The best indicator of iodine status in a population is the median urinary iodine concentration, UIC. Since most dietary iodine is eventually excreted in urine, UIC reflects recent intake. A median UIC below 100 ngl indicates insufficient iodine intake in a population. Levels below 20 ngl indicate severe deficiency. Individual assessment is harder, but urinary excretion is the main method.
Iodine deficiency disorders, IDD, are described as a major global public health challenge. What's the scale of the problem?
It's huge. Despite progress with salt iodization, it's estimated that nearly 1.5 billion people, about 1 in 5 globally, remain at risk of insufficient iodine intake, living mainly in developing countries. IDD represents the world's single greatest cause of preventable brain damage and mental retardation.
Preventable brain damage, that's staggering. What are the specific disorders encompassed by IDD?
IDD refers to the entire spectrum of effects resulting from iodine deficiency throughout the life cycle. The most visible sign is goitre, which is an enlargement of the thyroid gland.
Why does the thyroid enlarge?
When iodine intake is low, the thyroid can't produce enough T4 and T3. The pituitary gland senses this and increases secretion of thyroid-stimulating hormone, TSH. TSH stimulates the thyroid gland to trap more iodine and produce more hormone. Chronic TSH stimulation causes the thyroid cells to grow in size, hypertrophy, and number, hyperplasia, resulting in the visible goitre. Initially, this is an adaptive response to maintain normal hormone levels, euthyroidism. But if iodine deficiency persists or is severe, the gland eventually fails, leading to hypothyroidism.
What are the consequences during pregnancy and early life? This seems the most critical period.
Absolutely. Iodine deficiency during pregnancy is devastating for fetal development. Maternal hypothyroidism increases the risk of miscarriage, stillbirth, preterm delivery, and congenital abnormalities. Even mild maternal iodine deficiency can impair fetal brain development. Severe deficiency leads to endemic cretinism.
Cretinism.
Yes, endemic cretinism is characterized by severe, irreversible mental retardation, often accompanied by neurological deficits like deafness or deaf mutism, spastic diplegia, muscle stiffness, especially in the legs, squint, and impaired motor skills. There is also a myxedematous form with severe hypothyroidism, short stature, and delayed sexual development. This brain damage occurs primarily during fetal life and the first few postnatal years when the brain is rapidly developing and dependent on thyroid hormone.
What about iodine deficiency in neonates and children?
Neonates born in iodine-deficient areas are at risk of neonatal hypothyroidism, which, if not detected and treated promptly, via newborn screening programs where available, leads to permanent cognitive impairment and developmental delay. Even mild to moderate iodine deficiency in childhood, without overt hypothyroidism or cretinism, has been linked to lower IQ scores, impaired school performance, and reduced cognitive function. For example, poorer fine motor skills, slower reaction times. Iodine repletion in deficient children can often improve some aspects of cognitive and motor function.
Given this profound impact, especially on brain development, what's the solution?
The most effective, safe, and cost-effective strategy is universal salt iodization, USI. Ensuring that virtually all salt consumed by humans and livestock is adequately iodized has led to dramatic reductions in IDD globally. Public health programs monitor salt iodine levels at production and retail to ensure effectiveness. It's a true public health success story.
Incredible impact from such a simple intervention. Okay, finally, let's just briefly circle back to iron. We touched on it earlier, but it remains a huge nutritional problem, particularly iron deficiency anemia.
Yes, absolutely. Despite knowing about it for decades, iron deficiency and its consequence, iron deficiency anemia, IDA, remains the most common and widespread nutritional deficiency in the world, affecting billions of people, especially infants, young children, adolescent girls, and women of childbearing age, particularly in developing countries.
You mentioned prevalence data from India earlier.
Right. Data from India's National Family Health Survey, NFHS 4, 2015-16, showed that over half, 56% of urban and 59% of rural children aged 6 to 59 months were anemic. While not all anemia is due to iron deficiency, it's the leading cause by far.
And the consequences go beyond just feeling tired.
Far beyond. Especially in young children. Iron deficiency has serious and often irreversible adverse effects on cognitive development, behavior, and motor skills. It impairs neurotransmitter function and myelination in the developing brain. Deficient children may have lower IQ scores, poorer attention spans, and developmental delays. In adults, it causes fatigue, reduced work capacity and productivity, impaired immune function, and problems during pregnancy, increased risk of preterm birth, low birth weight, maternal mortality.
So another micronutrient with profound impacts on health and human potential, outro. So we've really come full circle, haven't we? We started this deep dive thinking about how small things can have these truly colossal impacts. And honestly, there's probably no better example than micronutrients.
It's absolutely true. These seemingly tiny components, vitamins and minerals needed in milligrams or even micrograms, are in fact the fundamental architects of our growth, our development, our energy, our immunity, our very fundamental health.
The complexity and the interconnectedness are just astounding. We saw how vitamin A is crucial for vision, but also immunity and growth.
How vitamin D, the sunshine vitamin, orchestrates calcium balance and bone health through intricate hormonal regulation.
How the B vitamins act as essential coenzymes driving countless metabolic reactions.
And how minerals like iodine are non-negotiable for brain development, or iron for carrying oxygen and cognitive function. Each one has its specific vital role.
And it really drove home how easily imbalances can occur, either through deficient diets, absorption problems, or increased needs, often with severe, sometimes hidden consequences.
Exactly. This deep dive, we hope, has given you, our listeners, a really robust, almost professional level understanding of why these tiny compounds matter so immensely. It's not just about preventing classic deficiency diseases like scurvy or rickets, though that's critical.
It's about optimizing health, right? Supporting healthy growth, cognitive function, immune resilience, but basically unlocking our full human potential.
Precisely. We hope you can now appreciate the sheer elegance of these biochemical pathways, these intricate dances of molecules, and the profound implications when they get disrupted.
So, as you reflect on all this information, maybe consider the The silent, often invisible impact these micronutrient deficiencies have on global health and potential, it's quite sobering.
It is. But the knowledge is also empowering. Understanding these tiny yet mighty elements, how they work, where we get them, who's at risk, allows us, both individually and collectively, to make significant differences in well-being here and around the world. The power to improve lives, surprisingly often, really does lie in understanding the smallest details.
Thank you so much for joining us on this incredibly detailed deep dive into the world of micronutrients. Until next time, keep exploring, keep questioning, and keep diving deep.